It's really a pleasure to be here. I appreciate so much the invitation. It's been a wonderful partnership with Let's Go and with Tori in particular. I also want to thank our faculty, the faculty for this, many of the speakers here, Reggie and Sandy, Tori, internally on our staff, Sheikh Anand, who leads our program, but you're all the faculty for our obesity work. You're on our, what we call our National Advisory Committee, and you provide the content expertise for us to be able to doing the work in obesity. NICHQ, as you said, is about 12 or 13 years old. We started in 1999, initially as a program of the Institute for Healthcare Improvement. We've been independent since 2002, and that's around when we started working on obesity. Our vision is optimal health for all children. Our new mission statement, not yet officially rolled out, but I'll still say it anyway if you don't tell our marketing director, is to better children's health and healthcare through quality improvement. So that really reflects what we do. Topically, what we've been working on has been this area of obesity, where we've been working for a very long time. We also do, at this point, a significant amount of work in the perinatal, improving birth outcomes. A lot of that work is around breastfeeding support, baby-friendly, and that connects to this. And we've had long-standing work in the area of improving care for children and youth with special health care needs, chronic illness, and that does relate as well to some medical home work. So if you're interested in any of those, I'm more than happy to talk to you. We have a wonderful staff that's fully committed to this work, a growing staff. If any of you live in the Boston area looking for work or have children who are looking for work, please let us know because we're actively recruiting. So that's who NICHQ is. What I'm going to do, and it's always challenging and inspiring to follow a speaker like Sandy, who is both a national leader but also a clinician in the field on a day-to-day basis and gives you that warmth and experience as a clinician. I'm a pediatrician as well. I practiced for about 20 years, but it's been well over a decade since I've been seeing patients. So I don't have that direct warm encounter and ability to do the direct counseling and conversation. So I'm going to be talking a little more about how the national agenda ties to what we're asking you to do in your practices. And I hope that will still be warm and relevant to you and hope will stimulate some conversation. So we'll try to be going back and forth. I do want to thank my colleague Sheikh Anand, who really helped me prepare the presentation for today. Let's see. So what are we going to cover? Why obesity is the focus of national attention? Duh. We'll get to that. But really how this connects not only with your passion about addressing this epidemic, but really how it fits with the broader efforts to reform and reshape our healthcare system and how there are a number of streams that are coming together in a positive way, I think a positive way. A little conscious, I love, Sandy, your comment about not judging patients. I would not say that all the folks out there aren't judging you as providers, because that's part of what's going on here and not always from the we're here to help perspective. But nonetheless, there is that broad national movement to improve healthcare and improve health, which can support the kinds of changes that many of you are committed to making. We'll talk about what you can do, although some of that has been covered in and out of your practice, and talk about some of the national initiatives that we've been privileged to play a leadership role in, and I know many of you are from teams that we have the privilege of working with, so I'm excited about that. And also give you some resources that I'll flash on the screen, but will be available as this slide set is put on the website and available to you afterwards. So in a sense, and I probably could have come up with a better graphic for it, but there is, in a sense, a perfect storm in a positive sense. I mean, people think of a perfect storm as got all these god-awful things happening which make, swordfish ships crash out in the sea. What I mean, in a sense, is there are multiple things happening that, in a sense, are coming to a very positive effect, from my perspective, on why you're here and how I hope the changes in the healthcare delivery system and in national streams are going to accelerate your efforts to improve care. There is actually, at the national level, for the very first time, albeit not as well funded as any of us would have wanted, but for the very first time, a real attention on the health of the population and a real acknowledgement for the very first time that says, gee, all the bazillions of dollars, or trillions really, that we're investing in healthcare are supposed to result in better health. And let's think about what can cause better health. And let's think about how we can align our efforts to do that. Of course, there's the really big elephant in the room, and I'll talk about that more in a minute, is the cost of health care. And that's what's driving a lot of the health care debate, which is, gosh, we're spending an ever-increasing proportion of our society's resources on health care, and is that really what we want to be doing compared to education or entrepreneurship or variety, innovation, all kinds of other things that we'd like to be doing, spiritual growth. And part of the strategies then to do that combine this interest in public health and addressing costs, is a focus on healthcare system redesign. Now, all of those three forces are affecting you at the bleeding edge. I mean, that's affecting you in practice. This focus on public health, this focus on costs, and this understood desire to redesign the healthcare system. So let me give you a little more depth on each of those and see how they play out in our work on obesity. Now, you know about the obesity challenge. You've heard about that from Reggie and others. This is just images of food, some healthy, some less healthy, and we could similarly put up images of television advertising and a variety of other things. And you know, of course, that the epidemic has tripled. My reading of the data on child health, Reggie, you probably talked about this while I was trying to find my way around Portland, which says at least at the child level, overall, the epidemic is somewhat level. Adults still moving in the wrong direction for sure, and disparities continue and are likely to worsen. So, but the epidemic is certainly there, 3 times the impact, and this is, I think, old Arkansas data that Joe Thompson shared with us a while ago that says costs certainly go up. The costs of being overweight, they do go up. They're only a small amount up in young childhood. The real actual dollar costs from the Harvard Pilgrim Healthcare Delivery Organization perspective, or the Mass Health, or the Maine, the Dorigo, I think that's your Medicaid name up here in Maine. Dorigo, I'm sorry. I always wondered how to pronounce that. The actual costs start going up in adolescence. They go up more in late adolescence. They become really significant as young and older adults. So again, there are phenomenal health impacts which we know about. And just to show you, these aren't old slides. I just pulled this down from the web last night, just so you could see we try not to use too many old slides in our presentations. This week's British Medical Journal. And this, of course, came out in the AAP summary that I get in every day, and most of you probably do as well. But I did pull the real reference, and it really says all these things. That says, actually, overweight and obese children in childhood have substantial increases, and this was a meta-analysis of 50,000 studies that included 50,000 children have increased blood pressure, increased lipids, increased insulin resistance, and increased left ventricular mass by the time they're adolescents. So very substantial health implications. So cost implications, especially later. Now, the importance of the especially later is it takes a fairly visionary organization or a visionary leader in government to be thinking about costs that are going to be incurred later. I mean, we might say you should support breastfeeding, or you should support providing children to have access to healthy foods, or you should create resources for young children so they can become physically active, or we should invest in home visiting to teach families about how to eat. And it takes a visionary organization that is not acutely worried about their bottom line, when you can say, and the actual cost return, the benefit to you should happen should you live that long. I mean, it'll be 10 or 15 or 20 years till Harvard Pilgrim is likely to see a cost return on their investment in these children. And so it does, that's typically why it comes out of the foundation part and not the operating part of many of these organizations. And it requires a visionary leader, and I won't tell you who I'm voting for, but we're seeing Michelle Obama doing some pretty tremendous things to talk about the long-term future. It's not a short-term return, and that's a challenge. And again, this is just an image from the Weight of the Nation video, but you're clinicians, you know that people like me increasingly talk about graphs, and we talk about numbers, we talk about costs, and we talk about epidemics, and you're the one who are actually seeing real patients who do experience real diseases and have these effects. So it's the population health impact, but it's also the individual impact that we need to pay attention to. Now, this is a model that we developed a long time ago, and I've got to come up with a better graphic. But the point of this graphic is, what does it really take to prevent obesity and to focus on this kind of work? And the point, as the Let's Go model shows, and much of our work, Collaborate for Healthy Weight elsewhere, is it takes a lot of people in a lot of organizations working in a number of places, multiple sectors, working together to make a difference. So we're all here representing the largely primary care, a few specialists working together in your clinical practices, and we'll talk more about that, doing very important things. I gather that Tori gave a message that I missed earlier about positivity. Let me give you a positive message. When I started talking about this work, Tori and I largely started talking about this work being tutored by Reggie and Sandy 10 years ago. Saying that healthcare had a role in addressing the epidemic was heretical. The first set of IOM, Institute of Medicine reports on what should be done about obesity didn't have anything about what any of us would do. It wasn't even on the table. We don't have those arguments anymore, and I'll be giving you examples of newer reports. The IOM is saying as one of their 5 pillars, healthcare needs to be more deeply engaged. So that's been a huge change in recognizing our potential role. So we have roles as clinicians, and this will be a recurrent theme in my talk. And part of that role as clinicians, of course, is what we do every day. It's what we went to professional school, whether it was medical school or nursing school or nutrition graduate school. We counsel individual children and their families to try to affect their behaviors. However, we are also important members of our community. And you've heard a lot about that, and you'll hear a lot more about that. So we need to have an impact, and that's this horizontal line in this diagram, in our local communities, either directly by becoming involved in the leadership of those communities, or in advocating, or in writing, or getting involved with other organizations in your communities, or getting directly involved in the schools, challenging as that has been. And there are also policy activities, both at the local level, but also at the state and national level. And again, Sandy already talked about trying to influence the Delaware State Department of Education. The schools, we're working with Lauren Smith and the Department of Public Health in Massachusetts. I mean, they can change with the stroke of a pen everything that is offered in every school in the Commonwealth by simply the way they do their purchasing. And so all of these different things are connected if we want to improve health and address this epidemic. So that's a little of the context. So you've already heard some of what the expert recommendations are. Let me give you a little more information, again, to convey that this landscape has changed from when we didn't have a role to now we are increasingly have a role, and the role that we have is increasingly clear. Now, this is from the Institute of Medicine on the clinician role. Pediatricians, family physicians, nurses, and other clinicians should engage in the prevention of childhood obesity. Healthcare professionals should routinely track BMI, offer relevant evidence-based counseling, and we'll come back to that, and guidance, serve as role models, and provide leadership in their communities for obesity prevention efforts. So that's pretty clear. And in fact, that's going to be a very consistent theme as we go forward. Risa Lavizzo-More, who's a geriatrician, but nonetheless focused on young children and the childhood obesity epidemic. JAMA editorial, very clear on that, and they put their money where their mouth is, $500 million invested in addressing the epidemic. Physician activity begins in the examining room, measuring BMI, evidence-based prevention, treatment strategies, and then must extend beyond the waiting room, and we'll be examining room. The most recent IOM report, and this is what I just referenced, went a little more explicit. So they were giving a variety, 5 overarching goals for what needs to be done to accelerate progress in obesity prevention, make physical activity an integral and routine part of life, again, not something tacked on, but something we do every day. Create food and beverage environments that ensure healthy food and beverage options are the routine, easy choice. Transform messages about physical activity and nutrition. Expand the role of healthcare providers. Hooray! Insurers, Isn't that nice? And employers in obesity prevention. In parenthesis, healthcare providers, as well as organizations like NICHQ, are not only providers of healthcare, but we're also employers. So we have a role in obesity prevention, and then making schools a national focal point. So let's delve a little more deeply into that. So the IOM suggests, so what should healthcare providers do? They should provide standardized care. Now that's interesting, and advocate for healthy community environments. So that says adopt, but it shouldn't not only, from my perspective, not only adopt, but consistently implement. How do we reliably deliver to every patient recommendations consistent with the kind of detailed expert guidelines that both Reggie and Sandy articulated? Adopt standards of practice for prevention, screening, diagnosis, and treatment, and advocate on behalf of your patients for greater opportunities. And there are a variety of indicators the IOM suggests, such as, again, monitoring BMI and increasing physician office visits. Interesting to me that they don't recommend an indicator related to advocacy, seeing as they did have a suggestion there. And they also suggest this idea that we as healthcare providers, and again, groups like Long Island Jewish, which is trying to, North Shore, trying to take over, well, you're a big employer. I mean, the biggest employer in Eastern Massachusetts is Mass General and Partners. I mean, we're not trivial organizations in terms of the way that we affect the workforce. So access to healthful foods and beverages, and you notice Mayor Bloomberg is doing something about the healthy hospitals in New York City, got a little pushback in the Times yesterday. Increase opportunities for physical activity as part of wellness, offer health benefits that include coverage for obesity-related service, and models for incorporating into practice. So that's, again, you've heard a little of that, slightly different framing from where we are at the national epidemic. Well, this is the costs, and this is simply the cost of healthcare. This is the proportion of GDP that's allocated for healthcare. And you can see it's going up. It's going up a lot. 1961, it was only 6% of GDP. Now it's somewhere around 17%. It threatens, is it inherently bad? Well, some people say, well, it's not really so bad. What's wrong with having a society be able to spend money on healthcare? That's a lot better than building bombs, for example, and I couldn't argue with that. But for example, and again, I'll be a little provincial in being from Massachusetts, we spent a lot of time in Massachusetts advocating for education reform. And we said a critical part of education reform is paying teachers more. And we raise taxes. We do that every now and then in Massachusetts. We raise taxes to pay teachers more. It's a beautiful thing. 10 years later, how did that play out? Every penny of that increased taxes that went to the towns to pay for teachers went to pay for their health care. So that's not good. Children are not learning better because we are spending more money on teachers. It's all coming back to the healthcare system. So that's what's driving a huge part of our efforts to reform the healthcare system. So that's one part of what I call, some people used to call it this iron triangle of access to healthcare, costs of healthcare, and quality of healthcare, and they're all related. So one problem, the one we're all really focused on, is the cost challenge. Another is what I'd call the quality challenge. So you're all fantastic. Just like Reggie said, everybody in Colorado thinks they're healthy. It's the person next door to them that's weight might not be so good. We are all magnificent providers. We provide excellent care to our patients every day. However, when bean counters come and audit our records using standards that we actually develop ourselves using experts, we really don't do as well as we think we are. And in fact, on average, the national data, and this is nothing new, the national data say whether you're an adult walking in an adult practice or whether you're being brought into a pediatric practice, the odds are that the right thing is done 50% of the time. That is, if I audit your records about whether it's immunizations, or whether kids are getting all their asthma medications, or whether they're being screened for all the appropriate things, or whether they're monitoring for ADHD with appropriate monitoring, these are the kinds of consistent standards. These are the pediatric measures. Again, a little better or a little worse than a flip of the coin that the right things are done. So that's the quality challenge. So costs are going up, and we're not getting what we're paying for. The people like me who work in the quality space have been advocating for a decade or 2 decades to do a lot of different things, which in a sense don't make sense to people who aren't out there. Why are you asking to do all these different things to change the healthcare system? Well, actually, that's because largely they're pediatricians who are advocating for this, and we actually think the healthcare system has a learning disability, has a problem with learning, and we think that if we can motivate the healthcare system to pay attention, if we can give the healthcare system the ability to gather and process information, and then to use that information in a productive way, just like a kid with a learning disability, if we can motivate them to learn, allow them to listen and focus on what the teacher is providing them, and then use that input to produce written or oral materials, then we would be better off. And if you look at all the strategies that people like Don Berwick and me and others have been articulating for the last decade and a half, we do things like engage families in the process to motivate. We talk about realigning the payment system so that it is aligned with providing the right care. We talk about transparency because none of us want to see that 50% performance from our practice on a website. We talk about giving everyone electronic health records and paying them for adopting it so that you can have a mechanism to collect information about the healthcare system. And we talk about creating resources that help organizations do improvement in order to change. Well, those are, if in fact you had nothing else to do in your day and felt like reading the second 1,500 pages of the Affordable Care Act, I mean, the first 500 pages talk about how do you get insurance to everybody. But the other 1,500 pages talk about how are we going to design our healthcare system. All those things that I talked about, there is some, it's like a Christmas tree. There is something in it for everybody who's said anything about quality improvement for the last 20 years in that second half of the Affordable Care Act. Part of what's in there is saying that the country needs to develop what's called the National Quality Strategy. Another thing that says is we need to develop a national prevention strategy. Well, those actually have been developed. The national qualities, I know I'm losing a few people here, I'm sorry. I'll bring it back to obesity because you didn't come here for a talk on health reform. The National Quality Strategy says there are 3 purposes to our healthcare system. One is to improve health, I mentioned that. The other is to improve quality of care, and the third is to lower the cost, so what Don Berwick framed as the triple aim. And a big part of that redesign system that's in the Affordable Care Act is to strengthen primary care, because there's a lot of data that the late Barbara Starfield amassed that said, if you look at different counties in this country, or states in this country, or compare countries, one of the reasons we get such poor value from our healthcare system is we don't have a decent primary care system. Not that we're not all smart, caring people working our tails off every day to provide excellent primary care, but we don't have the infrastructure, we don't have the investment to produce the kind of better systems. So, and if I was talking, as I am, to all of you who are primary care clinicians, you'd say, well, of course not. We don't get paid well to do that. So part of the strategy is payment redesign, and we'll talk about that. There is also, and you probably didn't spend a whole lot of time reading it, but there is a national prevention strategy developed by the Surgeon General and a committee, and it says that the goal of the country is to change our health system from an illness system to a health system, and it talks about creating healthy community environments. It talks about building clinical preventive services, and one of the top priorities is, shockingly enough, healthy eating and active living. So this is about primary care redesign. This is from a guy named Paul Grundy, who's a big VP at a big corporation, IBM, and the corporate world has said, we are tired of paying for garbage, meaning they're paying big bucks for the healthcare system, that line going in the wrong direction, and these large multinational corporations are looking at the value they get from their European counterparts, and they look at the value they get for the US, and they say, we're paying a whole lot of money for what we don't want, so we need to rechange the system. They've created something called the medical home. Now that's what you've all done in primary care, but more systematically in a way, and in a way that's more able to be proven in a certain way. And here the elements of the patient-centered medical home, again, grew out of pediatrics, but now endorsed by all the professional primary care associations. Lots of debate about whether it has a personal physician and a physician-directed medical practice. We won't go there. Whole person orientation, care coordination and integration, quality and safety are hallmarks, enhanced access, and payment appropriately recognizes the added value. That last part was not added by the pediatricians. That's the part that we forgot when we were working on it for 20 years. This is a graphic of what a medical home is. It's again, the idea of payment for added value is the foundation, that there's a personal physician, you have easy access through that open door, it's oriented towards families, quality, and safety. So I do all that to say there's a tie back to that in obesity, which is if part of what we're intended to do is have a standardized way to get the recommendations that Sandy talked about to deliver to every child, you need to have systems in your practice that enable you to monitor and reinforce, enable you to have that team to do it, enable you to coordinate your services with community resources and with specialty resources like Sandy's clinic. And if Harvard Pilgrim, not the foundation part, but the other part, is going to pay you more for doing that, they're going to want some evidence, in fact, that says you really are doing it. And they're going to have metrics, in fact, that say, are you doing the things that we want to be done or that we view as part of quality of care? And those metrics could be all related to the management of adults with diabetes, but that wouldn't help us all. Or they could include, for example, metrics around how do you provide systematic preventive services to children and families at risk of obesity. And in fact, they do. And that's where the connection is between the health issue that we're talking about, between the medical home issue that we're talking about, and the health reform issue. So for things to move into the quality space where there's actually performance measures around things, there needs to be sufficient evidence, at least in most cases, to support that. And that has been a barrier at times in the obesity space. When we started working on this, we would say it's the right thing to do when we're extrapolating from what happened in the smoking field and we're going to apply it here. We said, we know in smoking that if clinicians give appropriate advice, then people are less likely. And so it should apply to the area of obesity. And we banged our shoe on the table and some people believed us. But fortunately now there's more and more evidence. So the group called the US Preventive Service Task Force, I'm sure you've all heard of it, back in 2005 gave one of their infamous I recommendations. Insufficient evidence for or against, making a recommendation then. They did an evidence review, 2008, said, yeah, some of these therapies actually work. Behavioral therapies work in specialty and school settings if delivered with enough intensity. Drugs work and surgery works. Well, that still made me a little nervous because it says, well, that's not what we're doing in primary care. But that still supports the screening process. Because if you know that there are more intensive services that work for children who are over the 95th percentile, you need a systematic way to identify them and get them there. So that led the US Preventive Service to recommend that clinicians screen children for obesity, offer them or refer to intensive counseling. So we got an evidence base. Now, I was on the US Preventive Service Task Force 10 or 15 years ago, and we made our recommendations and nobody paid a whole lot of attention to it because we were just one group, lots of other groups. But that, again, that other 1,500 pages of the Affordable Care Act that none of you read said, actually, if the USPSTF recommends it, it's paid for. So that's very important. In children, it also gives the Bright Futures guidelines, those same it's paid for recommendations. But again, so this kind of recommendation is important. Many public and private insurance plans are moving to paying for quality, duh. And BMI assessment, nutrition, physical activity are increasingly part of it. There are three ways that that plays out. One is meaningful use. How many of you have garnered resources for your practice through meaningful use standards? So a few of you. Actually, probably about 25, 30%. HEDIS, how many of you know what HEDIS stands for? Oh, good number of you, okay. And UDS, which I didn't even know what that stands for, but it's Uniform Data Set. So we'll go through these briefly. Meaningful use, you know, as for part of the stimulus bill, long time ago, new dollars to stimulate our economy. There was a lot of money to trigger adoption of electronic health records. It's done in 3 steps, phase 1, phase 2, and phase 3, very exciting names. And you know that in phase 1 and in phase 2, the idea here was in the old days, again, in the old days, if you bought an electronic health record, that was fine. Now it's the electronic health record actually has to do something useful for patients. And one of the things that it has to do that's useful for patients is measure and report on BMI. So that's a beautiful thing. So here it is. Core objective, enter weight and height, structured data, calculate BMI and graph for children 2 to 20, 50% of your patients, 80% in stage 2. And then there are also clinical quality measures that relate to that. I'm conscious of the time, so I'll pick up the pace a little bit. HEDIS, again, used to be called the Health Plan Employer Data Set. Now it's called the Healthcare Effectiveness Data Set. Interesting to me that it changed names. 90% of plans in the country use it. Most state Medicaid agencies also are based on HEDIS. I won't spend a whole nother 20 minutes telling you about the Child Health Insurance Program Reauthorization Act, Medicaid performance measures. That would be another talk. But they have also adopted BMI as one of their measures. So again, there's a HEDIS measure around counseling for nutrition, physical activity, children 3 to 17. It's BMI percentile. There's a whole lot of information on what needs to be included in that. These will be on the slides. You have to actually document that you did something quite specific to each of those. It's simply saying you met measures. The UDS measures are the measures that community health centers, how many people here work at community health centers? A few of you, terrific. So they also have now adopted in 2011, BMI percentile, nutrition counseling, and physical activity. Again, quite similar to the HEDIS measures. Very exciting for us to see that those have moved forward. So the patient-centered medical home is the vehicle through which standardized care should be delivered. You'll be hearing more in the breakout sessions about the elements of the medical home, and the chronic care model, or the child health model, however you want to call it. And then these performance measures are there. Now, there are lots of other national initiatives. You've all heard of Let's Move, the First Lady's initiative. She's been a tremendous leader on this. There is a component of that, which is called Let's Move in the Clinic. Again, healthcare providers should join Let's Move. Second, make BMI screening a standard part of your care. Third, talk to your patients about breastfeeding and first foods. You've heard a little bit about that already. Prescribe activity and healthy habits and be a leader in your community. I must admit, we've already had a couple conversations about prescribe. I think as you hear in the breakout sessions more about how we talk effectively with our families, the prescribe model, at least as it's traditionally done, is not necessarily what I'd say is the approach we should be doing. That is, hi, I'm the all-knowing clinician. I'm the physician. I know more than you do. Here, I'm going to tell you what to do. Write a prescription. Please, turn off the television. The likelihood of that actually working is somewhere between 0 and 0%. So I would use the term prescribe loosely rather than, and you'll hear much more about that in later sessions over the next 2 days. But there's a pledge. There are actually excellent family fact sheets that you can use. You can commit to doing a practice that will do that. They suggest reviewing your chart, reviewing charts, again, something that we would do, that EQIP would do, a variety of other things. This is the prescription for healthy living from the Let's Move website. Again, all good elements, 5210. It's the right messages. It's really a question of how do you communicate about those messages and how do you engage families. And again, I'm talking in part about prevention, where I think the need, whether it's prevention or treatment, there needs to be shared goal setting and coming up with differences. But as Sandy said, the acuity and the urgency with which you'd move people through that developmental process is greater when you have somebody who is 400 pounds compared to somebody who is, just passing up through the 85th percentile. Let's Move in the Clinic does have some good information on how to be a leader in your clinic and in your community, and you can talk about that. I haven't even talked about the wonderful Collaborate for Healthy Weight program, which we have been pleased to lead. We have many teams that are here from that, and I'm thrilled to have you there. This is a program which the Health Resources Services Administration is supporting with us. It is funded through the Public Health and Prevention Trust Fund of the Affordable Care Act. We have many of the faculty in the room, many teams in the room, and I'm just so excited about it. We do know that the QI can definitely improve processes of care. This is from the Greater Rochester Obesity Collaborative, and showed that you were able to influence the ability to basically, again, if you take that first IOM recommendation of implementing standardized care, we know that through QI processes that enhances your ability to have standardized care. We're running this Collaborate for Healthy Weight collaborative through a series of collaborative processes. We've run 2 consecutive collaboratives, one what we call a pilot program with 10 teams face-to-face, now 40 teams, some of in the room, through a virtual process. We're through the second learning session, the virtual second learning session in that progress, and it's I'm going to have to go quickly. I'm conscious of the teams, the time, the teams are here. We've identified, the faculty has identified 6 strategies for community change. The idea of developing not only an individual practice plan, but a community plan, because it takes multiple sectors working together, using a consistent message like 5210, having a mechanism for weight status assessment, which doesn't only have to be done in the clinic, can be done at the Boys and Girls Clubs or the Y, after-school programs. Individuals need to have a healthy weight plan. Again, doesn't need to be developed by the physician. There needs to be the capability in the community with resources to be able to help all those individuals execute their healthy weight plans. And again, part of the idea is to change that environment. This is a strategy map from Chula Vista, San Diego, which is you'll have access to. You can't read all the details, but the point here is it's a mechanism to look at how can you implement each of these 6 strategies in each of the sectors that you're working with. And these are examples of some of the great messages. And again, we've given teams flexibility in their own community to adapt their own message that works for them. We've suggested using focus groups and communication so that all the partners in the community come up with different message, and these are some of the messages we've had. I'm going to flip through these pretty quickly, just because I want to give time for, right, this ends at, I could have gone slowly. I thought it was 11:30. I'm sorry. Well, I'm still going to wrap up and then give you a chance for questions for both speakers. I'll go back a little bit. One thing that we have found quite helpful, and you'll be hearing much more about, is this concept of a healthy weight plan. And that's much more extensive than the prescription that we talked about before. So the idea with a healthy weight plan is that they're individual action plans that can support healthy choices throughout a community. It helps individuals and families choose a behavior that's important to them, develop their own specific plan, and connect them to resources. All of you are likely familiar with the kinds of care plans that you develop for individuals with chronic illness. Most commonly, we see that in asthma. This is a little bit different, but it builds on that same concept of having a written plan, fairly consistent evidence that says having a written plan when you have a chronic condition is very helpful in helping you remember and move forward. This builds on that concept from the chronic illness literature and also from the motivational literature, on motivational interviewing literature, on how to go about making behavior change. So several of the communities have developed these plans. This is from Sarasota. It talks about starting with an assessment of individuals' habits, again, some of those issues of healthy eating and active living. But then it goes to the goal setting. And again, it's not our goal. It's the family's goal and a goal that's mutually arrived at. And the goals can change over time. You think about what relatively simple goals are. You talk about what information they have. And then there's the check-in process of how confident are you that you'll be able to take steps towards that goal. And if they're not confident, then you renegotiate the goal. Say, well, sure, I put up here that I'm going to exercise 5 days a week for an hour at a time. You say, how confident you do that? Well, no way. Well, then let's think of something different. So that's the concept here of coming up with a goal, a treatment plan, and then that you have this that you can check back on and review and refresh and say, okay, did you meet that? And if you did, that's great. Let's take the next step. And if you didn't, let's review, well, what got in the way? And do we need to change the goal, or do we need to just strategize different ways? And again, you'll be hearing more about that. And again, these are some of the common targets. And I think there are lots of ways to connect Again, I'm sorry, I'm flipping back and forth. I didn't expect you to copy any of these down. These resources will be available. But one thing I did want to convey is, in addition to all the wonderful materials that you're getting through Let's Go, and here, there is such a plethora of resources available for obesity that none of you should be starting from a blank computer screen with your Word, template up there. You all should be pulling down great resources from other places. There are communities that are connected. We long ago created the Childhood Obesity Action Network. It says advocacy, but it's really Action Network, which is a network, really just at this point, largely a listserv of a couple thousand people, 3,500 people who are committed and interested in this topic. And if you have a question, you just put it out there. If you're a pediatrician, there's the provisional section on obesity, same kind of thing, where you have a question about, like the question that was asked about sleep apnea or metabolic syndrome. You can just put those questions out there and get other people to respond. The Robert Wood Johnson community has an incredible amount of resources. They have a lot of GPS resources where you can say where you are, and it'll indicate what other resources are available in a geographically close way. We have many partners that we're working with in the Collaborate for Healthy Weight program. One of those is NATRA, which it's like the National Association of County and City Health Officials, I think, are organizations. It's basically the city and county public health officials in the country. They have great resources for individuals with disability. There's the Obesity Society. There's plenty of evidence syntheses out there. There are tools from the CDC. There are tools from NIH. Again, don't start from scratch. If you're interested in advocacy work, and again, you'll be hearing breakout sessions on that, Be Our Voice is a program that NICHQ, together with the American Academy of Pediatrics and the California Medical Association Foundation, put together. You'll hear more about that in a breakout today, but great resources on how you as a clinician leader can make changes in your community. NPLAN, got to be the world's, it makes NICHQ a very clear name to me. I can never remember what NPLAN stands for, but it is a wonderful group, a National Policy and Legal Action Network, I think, or something like that. Great organization with tons of resources about advocacy in your community. So lots of places you can go. So what should you do in summary to say what I said? One is start. It all starts, you're clinicians. You get up in the morning taking care of patients. That's what you need to focus on first. High quality care, including, again, the graphing weight for length of children up to 2, BMI beyond that, categorizing, using that information based on the expert recommendation, counseling all patients of healthy eating and active living, develop individualized health plans, and then you'll be learning new tools later through the day for those of you, evidenced by your being here, that you're interested in taking the next step. Moving beyond that, partner with community organizations. Again, the tendency in medical school is for solo actors. It may be different in nursing school. In your communities, I would be shocked if there weren't activities already going on in your communities. Try to join them. Parenthetically, you may not know how to work with them, and they may not know how to work with you. Lots of community organizations don't know how to work with busy, high-powered professionals who can only devote a little bit of time to doing things. So figure out how to work with them. Promote healthy choices at work and being a role model. I'm very interested in that. Again, you heard from Sandy about that. I think I'm thrilled that Mayor Bloomberg is doing something. There's another nonprofit organization in Boston called Healthcare Without Harm that has a Healthy Hospitals campaign, which is about a variety of things to help hospitals get healthier, including having the right kind of light bulbs and getting toxic vinyl out of their IV bags, but they're also working on getting healthy foods. I think nobody is really convening that activity about ambulatory primary care sites, community health centers. I think, again, I'm old enough that I remember, and my father was a physician, I remember going to the physician rooms in the hospitals, and they would be smoke-filled. And it's not that way anymore. We as healthcare professionals became leaders and role models. I think we need to do the same thing in this field as well. So I'm going to stop, give you a chance to ask Sandy and me further questions, and thank you for your attention. Please.
Hi, Charlie. John Bancroft from Maine. BMI is a great measure, and it serves some useful purposes. But especially as we're working with young people, we're often challenged because they're growing, and it almost by definition becomes a measure that is not consumer friendly. It can only really be measured and calculated accurately in our offices.
Right.
So though from a practical standpoint, I think it absolutely makes sense, as you and Sandy and others have pointed out, that we need to work with individuals and families on practical interventions that are changes in behavior or changes in environment. I find that patients, especially adolescents and their families, are often looking for that next step. Are the interventions that I'm doing, the changes in behavior, impacting that end result? And they can't tell until they come back to my office. What else do you use as a measure that they can track as an outcome measure?
Turn to...
So I think this covers the waterfront. If you think specifically about BMI, no, they can't do that. There have been some studies about using weight, say in college freshmen, and that allowed them to track. You have to be very careful about using weight. I don't use it often. So there's some perils in doing that because you don't want to trigger an overfocus on weight. I think they're not used to tracking their own goals. So many patients that come to see me are at a somewhat or very low level of self-efficacy, and they may not have ever set a goal like that and tracked it. Sometimes you can allude to the grades and the homework. So I think that the strategy here is we do a lot of teaching about goals. We try to increase self-efficacy, but you may be encountering a person who, for the first time in their life, ever set a goal, tracked it, and believed that change would happen. And there's some hope that has to get interjected, because many of my patients, and I'm seeing Reggie kind of nod his head, don't even believe that they can do something that will affect them directly. They feel that the environment and all the things they're dealing with are affecting them. So to me, it's around goal setting, but there's some underneath around the goal setting that you have to get to around the patient, because they may never have done that before. So Reggie, you want to talk?
I'll share your concern about tracking BMI, because it's not going to change very much.
Yeah.
But if you list several things, let's say the child has 5 sweetened soft drinks a day and doesn't do anything physically active and watches 2 hours of TV. So rather than say we're going to change your BMI and track that, I would say let's have 3 sweetened soft drinks next week instead of, a day instead of 5. You can track that. You can say, you used to watch 2 hours of TV a day. Now let's watch 1 hour of TV a day. We can track that. We can say you're going to walk around the block 4 times, whatever it is. But not, and the other danger of focusing on BMI is if it hadn't changed after 6 months, they're going to say, to hell with you, I've done everything you told me and nothing's happened. So I think you track the things that they can control, you track the things that you can easily measure, and you reward them for that. And tell them BMI will follow suit, but don't pay attention to that. I think you'll get more cooperation.
I'd also jump in a little bit. Again, some of this is a little bit of the tension between the public health perspective and the clinical perspective. I mean, you have a patient in front of you. You've got to talk to them, got to focus on their behavior. Again, both Sandy and Reggie said this prevention, the likelihood of success of the prevention agenda is higher, I think, than at least the short-term success of the treatment agenda. So we need to focus on taking care of our patients and providing them guidance. We also need to think about influencing a population's behaviors over time, so that over the next 5 years, we talk about bending the weight curve in the community. And the question you ask also does play out in the policy space, whether it's Karen, who has asked me this when I've discussed our program with her in the past. So Charlie, it's great that you're changing the way doctors are practicing, but have you changed the BMI in the community? And to be honest, the White House asks the very same questions about Collaborate for Healthy Weight. They wanted us to tell them when we got this funding, Charlie, are you going to be able to say that the BMIs in these communities are lower as a result of you working with them for 9 months? I said no. But they still keep asking. So it's a challenge. Tori?
I'll thing I was going to say, and John may want to talk about this too, there's been some studies that show that you can track how people feel about themselves, and that whole piece, that gets to the self-efficacy. So if somebody's weight doesn't change at all, but they actually feel better about things, they're on that path. And so I know the AAP's done some studies, and John, did you want to mention that or no? No. Okay.
So I just want to reinforce that because other things may get better. School life may get better. Quality of life we know is low. That may get better. So I think we don't talk enough about what's going well. So I always feel that we start our conversations in clinic by what's going well. Sometimes when things are going well, the parents and kids don't often connect what they've done. So I think we have a group, we need to do a lot more positive what's going well and reinforcing any self-efficacy that help things go well. How is school? How's the teasing? How do you feel? What are your behaviors? And then the end of the caboose on the train, I always say, is the weight. It's sort of the caboose. Everything else has to kind of line up.
Hi, I'm Hemmel Mehta, and I'm from San Mateo County. I have a question of my own, but I just wanted to respond to some of the conversation that has already happened. I think as a physician, when I see the family in my room, we start off the conversation with, hey, this is because they want to know about their child's height and weight. That's the first thing they want to know before the visit even starts into what is your lifestyle like right now. So that is the focus for the parents, and we start off then with explaining to them where their child stands in terms of his weight for his age and things like that. And then we go on to the lifestyle questioning, and then we go through the habits, and then we say these are the habits that will support a healthier weight. Now the parent has tied in the 5210 with the weight. So their first question when they come for a follow-up visit is going to be about their weight and their BMI, and they are not focused on the lifestyle changes that they have made, because now they're saying, now you said my child needs a healthier weight, and these are the habits, and now, so I did these habits, now where is my child's weight? So that is just from a pediatrician perspective, this is actually what happens at ground level. Regardless, the question that I had was, with respect to meaningful use and the HEDIS measures related to obesity, are they mandatory right now? Or is it an institution that is choosing which measures they are going to report for quality of care?
So it depends. It really depends on the health plan and the nature of the contracts. I'm talking about the HEDIS things. It depends on what your health plan is using and how they've tied that to contracts that you might have with your practice or your hospital. But these are it's pretty widely used.
They are widely used, but on researching about it, what I found was that the institutions can choose which measures they want to track. And coming from an institution that is adult-focused medicine, most of the times the pediatric measures are not what are voluntary.
So that's right. So the question was, if you're in an adult-focused institution, you're not likely to use these, and that's true. That's true. We try very much. One reason we want them out there is to have this available and to encourage institutions that, even if they're an adult institution, if they have pediatrics, they say, gee, this would be what we would like our practice to report on.
So can something be done at the national level where they say make some of these pediatric measures?
So what we're doing if you want them mandatory, be careful what you wish for. This does tie a little to what I said with the CHIPRA. So the Child Health Insurance Program Reauthorization Act, which was the second bill that President Obama signed, included that the Secretary of Health and Human Services would identify measures that state Medicaid agencies would be encouraged to use. Now, the feds can't tell states, because of federal relationships, what they should measure. But they can strongly encourage them through a variety of mechanisms. So BMI measurement is part of the CHIPRA endorsed standards, one of the 23 measures that are currently endorsed. So the federal Medicaid agency would like state Medicaid agencies to use that. They've actually given funding to Research Center to refine and improve that measure, and they're currently working on that as well. So that's, and the hope then is, or the hope for those of us, for those who think that these kind of performance measures drive quality, and we could have a long conversation about that. The hope is that if state Medicaid agencies start using that, that it will become easier for then the private insurers to follow suit within the state, especially on something that's already got fairly wide use. So it's kind of moving around. And then, for example, on the, even coming from the other way, the NCQA certification, NCQA being, used to be the National Committee on Quality Assurance, they certify health plans, but they also certify medical homes. They have the most widely accepted measure for determining whether you're a medical home. If you want NCQA certification, you need to identify one of a number of conditions that you could be certified in. And again, they initially were thinking of diabetes and congestive heart failure, but obesity is one of the conditions. If you can document that you have a registry, for example, that you measure BMI and that you can identify your people over 85th and 95th percentile and that you provide appropriate counseling and follow-up in sort of a chronic care management approach, that also enables you to get NCQA certification, which, if payment reform happens in your state or with your plans, could enable you to get enhanced payment from the plans. So again, there are a variety. That's why these pieces are kind of all connected.
Hi, I'm Steve Blumenthal. I'm still a pediatrician. And I'm glad that limits of BMI were brought up. There are several limits to it because if you think about it, we pediatricians don't measure BMIs until kids are 2 years old. We've already seen them at least 10 times by then, and then we see them once a year afterwards. So in a way, one other way of looking at the BMI, it's a useful tool, but another way is looking at how, in some ways, we are failing our children. By the time they're 2, again, the media is already on, TV is on. They may or may not be drinking lots of juice already, and if it's not brought up at 4 months of age, you may be too late. If the first food is a processed grain, good old rice cereal, processed grain, they're inculcated in that right away, then we may not be doing our job. And then a lot of what we're doing afterwards is trying to make up for what we haven't done with all the many opportunities we've had over the first 2 years of life. So it would be great to really shift a lot of the emphasis early on and look at those early years even with more focus to figure out how we can get better outcomes.
I know I don't disagree with you at all. It's been strikingly challenging, again, in some of the places that I've been lucky enough to travel, like the Robert Wood Johnson Foundation discussions, to get them to focus on the 0 to 2, whether it's concern out of the evidence, I guess, has been a little slower in coming in, although I think it's starting to get there. But it has been hard to convince some of the large groups to really do that 0 to 2 focus. But I personally think it's great. I think, like people have said, breastfeeding appears to have at least a modest effective exclusive breastfeeding up through 6 months appears to have a modest protective effect, and the kinds of dietary changes as well as health behavior changes. Again, Sandy has taught me that pediatricians can't say, don't get that TV. They don't want to hear from us. They think they're being good parents by providing exposures to educational opportunities. They think they're busy, which they are, trying to cook foods, and they need something to be caring for their child, and if it's the TV that's doing it. So we have to be very careful about how the messages are delivered, but I agree completely, and it is all about marketing on the TV. Go ahead.
So that is completely right on. So the Academy is releasing, we finally got it together. We did 22 focus groups around the country of parents of under 5-year-olds to just test messaging about how they want to hear about healthy behaviors based on the evidence that we do know about healthy behaviors. And we'll be launching at our NCE in October the HALF project, which has an outward-facing parent on our healthychildren.org parent website where they can get information about activity, feeding, and parenting in a parent-friendly way based on those focus groups, and a physician implementation guide for the under 5-year-old population that looks at evidence-based and looks at every visit with a real focus on anticipating when parents initiate these behaviors and getting ahead of the game. that is so right on, and I think we are using both evidence and parent information to drive this work. So look for that, and I think it's very clear that from Nick Stetler's data and many others that if they start crossing percentiles as young as 4 months, it's predictive of 1 year weight, and 1 year weight's predictive of later weight. So when you have a child, and you should be measuring weight for height, and when you're watching that weight percentile, that percentile cross, that's when you should be asking about healthy feeding and activity behaviors. And this goes right to the heart of the infant feeding dyad, with hunger and satiety cues, with breast and bottle feeding at the same time, with French fries at 6 months, and all the things that you see with cereal in the bottle, with lack of sleep and lack of routine. So this is exactly where we should be, and this is our wheelhouse as pediatricians. Right. This is our wheelhouse. We should be right in it. So look for that, and hopefully even more to come, so we can do this work.
And Elsie's going to be talking about that tomorrow.
Good.
Hi, I just had a question on if there is, or if there ever could be, some federal-led requirements for state Medicaid programs to pay for services with a diagnosis of obesity, seeing a nutritionist, going to physical therapy for children.
It's a great question. So the question was about federal payment through Medicaid. As you know, they have made such a requirement on the Medicare side. And I think the answer to it really rests in the very complicated and difficult relationship between the feds and the states about Medicaid. And again, realize from our perspective, Medicaid is critical. From the Medicaid director's perspective, they spend 2/3 of their money on nursing homes. So, when they're dual eligible, at least. So getting folks to pay attention to this is hard. So anyhow, I think it will be, I personally, one way it could happen would be if, when I say it could have happened if in the Affordable Care Act there was the provision of required health benefits that plans needed to offer through the health exchanges. That would have been a vehicle that the feds could have done that, but they chose to allow the states to establish their own required benefits. If the U.S. Preventive Service Task Force or an authoritative group like that comes up with some more specific recommendations, that might also help. But otherwise, it's very hard for the federal government to mandate a specific element of coverage through a state Medicaid program.
One last question. Yeah. I know we're trying to wrap up, so I'll be quick. My name's Jennifer Gilberg. I'm with the Greater Holyoke YMCA, so I sit at the table around the Collaborate for Healthy Weight work. We also offer another program. So I come from the community side of things, so I'm not a pediatrician. But I do a lot of work in our community around healthy weight. And we have another collaborative that's called Salsa Sabor y Salud, and it comes out of the National Latino Children's Institute. And one of the pieces that I wanted to share around goal setting that we have found very successful is they don't talk about what you should take away from your diet or what you should take away from just your family activity and what you do, but what you can add to it to make it healthier. And we found that to be really successful in the goal setting that we've done, because nobody likes to be told what they shouldn't be doing, or that you should, take that away, or that's not a good choice for your family. But what can you add to your plate to make it more colorful? Or what if you add more water? And so we've really worked that into the goal setting that we've done, and it's made a huge difference. And what we've seen is that the unhealthy things like the sugary drinks or whatever it may be start to kind of go away more naturally than saying you need to go to 3 soft drinks a day instead of 5, but why don't you add 3 glasses of water, and then those 2 extra soft drinks sort of naturally start to go away. So that's just been a really successful thing that we've seen on our end, and I just share that with the group.
Well, thank you for sharing that. That's very interesting. And Shika, I don't know if you want to comment. We've had intense debates on a Massachusetts-based
I'm just curious if that data has been published, because that's really interesting. And
I don't know. I can go back. I don't know if it's been published through the National Latino Children's Institute, but it's a big part of the Salsa Sabor y Salud program, which is a healthy living program for Hispanic and Latinos, which we have a very large percentage of in our
That's why I'm wondering if they, because I know that's been shown, and it'd be nice to have a study in like this to prove that. I mean, or to have supportive data.
Well, but I would say, for example, and again, Chick, if I'm wrong on this, tell me, but my understanding is Walter Willett, for example, has been pushing back very hard in a project that we're doing within Massachusetts about even the 5 fruits and vegetables things, because the evidence is not, it's like, it's good, obviously it's good. So our message is basically replace calorically dense foods with fruits and vegetables. So because the concern is if people start adding on 5 fruits and vegetables on top of their calorically dense foods, that they're not going to be benefiting. So it could be that if people start eating that they will eat less of the other, but we've had rather intense debates about how to message that, and we've been uncomfortable simply saying adding.